For our afternoon panel called Treating Drug Offenders Smart Practices to Reduce Drug Use and Recidivism, we have Mark Fontaine, who's the Executive Director of the Florida Alcohol and Drug Abuse Association, who is going to moderate this next panel. So let's give a warm welcome to Mark and his panel. Thank you, Mark.
So the Sheriff of Orange County reminds me of 35 years ago when I was involved in starting the first drug treatment program in the Orange County Jail, and what at the time was called Treatment Alternatives to Street Crime, which Chet will remember because that's kind of where he got started too. So one of the tasks my job was to go and talk to the police officers, talking to them why drug treatment was of value. Okay? So that's how we started. So I remember this particular shift at 5:30 in the morning down at the police headquarters, and I remember this sound of like swish, 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 and I was like, what is that? And then I watched about 15 motorcycle cops, fully dressed in leather, come and sit right there in the front row. And I thought, now this is a challenge to try to convince them that drug treatment, because back then, drug treatment wasn't accepted. We didn't have the research, we didn't have the data, we didn't have what we know today, the science to say, this is effective, nor did we have the studies to show how cost effective it was. And we have all of that today. So this panel is going to, well, it's not really going to be a panel. It's going to be a conversation. We're going to engage in a conversation, not a panel. And we're going to just talk about that. So let me start with a few fast facts, because fast facts will set the context. So what we're seeing here is the downward trend of drug arrests, both for adults and juveniles. Now that ties into the overall downward trend of all arrests for adults and juveniles. And I know the conversation was put out yesterday, which is, so if crime's down 30% in the last 10 years, then why do we need new prison beds? So I think that conversation needs to happen. So then when you go to the next thing, what you see is 25% of the new admissions to prison are for drug offenses. And when you add property crime to that, and we know many, many, many property crimes are connected to somebody's drug use, abuse. Matter of fact, we had one of our board members get attacked this weekend by a heroin addict in Delray. Basically trying to get money from her purse so they could go get a fix. So when you add that property crimes, it brings it up to 60%. So you see that there's a pretty significant impact on people going to prison because of drugs. Oh man, what happened? There, ooh, I'm not gonna touch this again. So, oh, I guess if I got to go this way, there. So then what you see is, and the legislature just did this last week, they're looking at, well, let's look at those drug crimes. What do those drug crimes tell us? And what you see there is 25% of the people going to prison is for drug possession. 52% basically for sale, manufacture, or deliver, and 23% for trafficking. We do drug treatment in 3 different correctional environments. Probation. So in probation, we take probationers and we say, you have a drug problem, you need drug treatment, and they either get outpatient or they get residential, secure, long-term or short-term residential. Then we have programs in prison, and we do those programs where we do what we call a therapeutic community, where all the inmates in the program are on one wing of the prison, or one dorm, half of the dorm, and the other one, intensive outpatient, is where inmates from around the compound come in for drug treatment. And now we started institutional reentry centers. Last year, the legislature funded Gadsden. And Gadsden is a 432-bed facility. 70% of the inmates there will be getting drug treatment. And they will be leaving that facility and going back into the community because they're moderate risk. So they will never step down into, most probably, into a community reentry or a work release. Then we have what we call the community reentry. And you've heard a lot of talk about the Bridges transition programs, transition house transition programs, reality house. These are programs where offenders are serving the last 18 months of their sentence in a community program, and then often stepping down from there into work release back into the community. I think Chet may mention that as we go. And so what you see is we're spending about just over $49 million in the Department of Corrections for drug treatment. Under felony supervision, 53% of the people on probation are in need of drug treatment, and about 49% of that 53 get it. Why they're in, but 95% of that is outpatient and 5% is residential. So we have this stepped up process where the judge at some point says, you know, you violated your probation 4 times, you keep getting high, you keep getting dirty urines, we're going to send you this residential program. And you need to make that or you're going to go to prison. And we're finding that to be very effective. Of those community beds, you see we have 1,176 of those in the community for probationers. At one time, we had 1,900 of those beds. And then the economy went down, so the last 4 years you've seen a decrease, and last year you started to see an increase. But you know what I find interesting as I look at this slide? Now we need 1,000 new prison beds. I wonder if we had these 1,000 community beds for the last 3 years, if we would still need 1,000 new prison beds, because these options, is the last stop before going to prison, were no longer available in the community. A rhetorical question I think it's worth looking into. So then we talk about behind the fence programs. And the Department of Corrections basically says that 64% of the inmates, the 100,000 inmates, need drug treatment. Last year, we released 22,967 inmates, and of those, only 27%, or 6,000, received drug treatment. So we have all these people that need it who are coming back into your communities not getting it. And finally, fast fact, the Department of Corrections budget, $2.1 billion operational budget, and less than 2.5% spent on drug treatment. When we have the situation that we've been talking about, we're spending that small sliver on drug treatment, something that we know is effective. So what we decided to do now is to have Dr. Holly Hills from the University of South Florida, Florida Mental Health Institute. She's going to talk about kind of what the research tells us about drug treatment for a little bit, and then we're going to talk about some opportunities that works, and we're going to finish out with an incredible story. So let me read this to you. We put together this book because if you remember, not too long ago, we were getting challenged about, does this thing really work? We need to be cutting drug treatment. Do we want to keep drug treatment, or do we want to give money to keep old people in nursing homes, and et cetera, et cetera? Well, when we got that challenge, what we did is we went and looked at the literature. And we over the last 10 years, there's been 18 major studies that say drug treatment is effective for offenders. And that's not including some of what Holly's going to be talking about, which is the drug court and other studies. And then another half a dozen studies that show that it cost offsets. But let me just read this one line to you, and then I'll give you Holly. Research demonstrates that providing treatment to individuals involved in the criminal justice system decreases future drug use and criminal behavior while improving social functioning. Don't all of us know that work with offenders that that's exactly what it does? And it's now great that we have research, and it's now great that we don't have law enforcement anymore questioning the value of treatment. More so, they're the partners in helping us get the treatment that we need in order to effectively serve people. Let me introduce Holly Hills, Dr. Hills.
Well, let me go to my first. I thought this was a very straightforward title to the talk here. And I feel like, same thing with Mark, I thought about giving the Laka from Taxi, for those of you who remember that show, version of this response, and say, drug treatment works. Thank you very much. So this is really I think the things that we're talking about today are really the distillation of a lot of different studies, and the great news, the same thing with Mark, is over the many years that I've been working in this field, it's been great to see more and more validation, more and more research, and better research come out. So I hope that the theme today will be of my presentation really that we've seen the convergence of evidence over 20 years' time, and we really can say we're getting better and better at doing drug treatment. We're getting better and better at defining outcomes. We're getting better and better at looking at what's the length and the term that we would like to see outcomes last over time. So we're still improving. We have a long way to go in a lot of areas, but I think we've made so much progress in the 20 years that I've been looking at this data and looking at the studies that are out there. So as Mark said again, I'm kind of collapsing across a lot of different investigations here to look at the continuum across the justice system. And one of the things that you have to look at in a lot of these studies is sort of the meta-analyses, right? So there's so many studies that have come out that one of the techniques that we use is really looking at the combination of studies to say, what do the findings show us? Because you can't read the sheer volume of research that comes out every year. You really want to see what's the distillation of the evidence for these programs. So one of the ways that we do this is to look at meta-analyses of the data. And part of that is, leads us to a consensus. Now, what you look at when you look at the Urban Institute's report and Mitchell's report on the outcomes from drug court, you really see how varied the programs are. So one of the big challenges of doing meta-analytic work is really that when you go around to every different jurisdiction, you see they have different levels of sanctioning, they have different target populations, they have different degrees of intensity of supervision, they have different degrees of consequences for negative outcomes, they have different alternatives in terms of sanctions and incentives that people might have. They measure different lengths of time. So one of the big challenges in this research is really to say, because we have so many models operating, how do we pull out the things that are the consistent variables across a lot of different studies and say, what can we say about the consensus of the research? And so what we can say, and these are based on, in these meta-analytic investigations, sometimes 150 different evaluations that are collapsed and extracted to get the variables that we're interested in. But what we see is that drug courts, on the whole, the substance abuse treatment interventions associated with them lead to reductions in recidivism from between 8 to 26% as compared to other alternatives, comparison groups. And those can be comparison groups where there's different levels of supervision in the community, but there isn't the same intensity of supervision and treatment that you would see in a drug court setting. So according to Mitchell's report, as I mentioned, that came out a couple years ago now, when they look at the studies that look at outcomes over time, you can see the effects up to 36 months. So that's great. It's fabulous, a conclusion from that investigation. We're always happy when people do better while they're in treatment, but the money's really when they're doing well after treatment, right? So that's what you hope to see, and that was a conclusion of his investigation, that you can see the effects over time. However, we know not all things are good, right? Not all should have prizes, because there is variability in the outcomes, and you want to make sure that you see the appropriate level of impact in the ways that you want to see outcomes emerge. 15% of programs are found to be ineffective, so it's not that all are good, but we need to really look at how are the ones that are doing well, how can we distinguish them, and what kinds of interventions are they doing. So importantly, in picking up on Ed Latessa's presentation from yesterday, the thing that we've also seen change in terms of substance abuse treatment in the last 20, 25 years is we've seen the emergence of greater and greater technical specificity in the research, right? So we see better outcomes because we have more data showing the validity of the programs, right? So there's more evidence-based practices available, and the other part of that is we've seen greater adoption of them over time. So I can't emphasize enough from his comments yesterday, we really want to see the adoption of those evidence-based practices, and we want ongoing monitoring of fidelity. So if you implement something but you don't see if it's still being implemented correctly 1 year and 2 years and 3 years later, you can't assume you're getting the same outcomes. So the fidelity, the adoption, the implementation, and the sustained fidelity is really, really important in this way. In terms of the cost benefits, when you look at the different investigations, and again, consistent with the Urban Institute report and others, you see the cost savings are significant for participation in the treatment elements of drug court and the supervision elements. So for each individual, typically because of the reduction in other crimes and the associated costs, that's the interpretation of the cost savings. Typically, we see these improved outcomes. So the costs are better, the outcomes are better, the opportunities are better for people when they participate in substance abuse treatment as a part of their drug court experience. This is a slide that just shows the differences between comparisons between programs and comparison sites in terms of outcomes across a series of studies, and the range here, as I said from the previous slides, about 18 to 26%, typically around rates of rearrest. When you look at the Urban Institute report, again, looking across the follow-up period in terms of rearrest, you see the drug courts have lower amounts and rates of rearrest. So we see good data coming from multiple sources, multi-site studies, and meta-analytic findings. When we talk about the outpatient treatment, particularly in populations of offenders, we see of probationers, we see fewer arrests across multiple investigations for persons in outpatient substance abuse treatment. Even in the high-risk probationers, we see reductions in recidivism, and we see the same thing, even longer lengths of reductions in recidivism following treatment. So the good news is there, we're building a huge body of evidence for that in terms of the effectiveness of substance abuse treatment. In national studies, we also look at, across different investigations, the pre to post-treatment recidivism rates, which people are really concerned about, is we see tremendous reductions over time in the rates of recidivism, and that are tied to these treatment experiences. When you look at the duration of treatment, this is one of the things that we look at in a lot of different studies, and the consensus opinion from the literature is that you have to have at least a minimal dose of intervention before you have any effectiveness. So at least 3 months of outpatient treatment is needed, and that's an extreme minimum before you would see any effects in any of these investigations. You see the greatest effects in terms of outcomes, impacts on a range of variables with between 6 and 12 months of outpatient treatment. And then over a year worth of treatment, you tend to see diminishing outcomes, meaning you still see the very positive effect, but you just don't see as dramatic a drop in these in symptoms or engagement in outcomes that you would like. So longer term isn't always better, but it really, again, depends on the subpopulation of individuals. And I would put the caveat there to say one of the things that we're still challenged with in substance abuse treatment, I think a lot, is looking at the population of individuals with co-occurring disorders. And I think we still can do better with that population, and we have some ways to go with the integration of services. And I'm hopeful, and I have seen a lot of change over the 20 years I've been looking at this, but we still have a ways to go to even further improve these outcomes. And they may be the individuals who are at the longer end of that tail, who need the longer term time. The data from the co-occurring literature would say that those are the ones that we need to invest the longer term interventions with. So the best outcomes, obviously, sounds obvious, but for persons completing treatment, right? So if you have met all the requirements and you're meeting what needs to be done, obviously, that's the best outcome you're going to achieve. We see, in terms of the debate about outpatient versus residential care, an ongoing debate, but we can find studies where both outpatient and residential outcomes for substance abuse treatment are effective. On the whole, there's a preponderance of the data suggests that outpatient treatment is more effective than residential treatment, particularly for drug-involved probationers and during reentry. So when you look at a lot of studies combined, the overall effects outpatient edges out residential care. When you look at cost-benefit analysis, as you would suspect as well, a similar thing, that we find a greater impact on a benefit-to-cost ratio for outpatient interventions over residential, if that is the measure of outcome that you're looking at. On the whole, again, echoing Ed Latesse's comments from yesterday, you're going to see the biggest outcome when you work with individuals who have the most serious challenges in terms of criminogenic needs, and also the seriousness of their, in terms of the seriousness of their overall history of crime. So they have the biggest change possibility, sort of a statistical artifact there. You're going to see the biggest change in that population. So one of the findings of the Urban Institute's report as well was to say, please think about expanding the criteria to the more challenging populations, to have more people be able to come into drug court, because we see that those people do as well as anyone else in the drug court settings particularly. So in the past, there's been a lot of perhaps exclusion of people in different categories, but when you do look at the data, it says people in a broad range of experience and outcomes and backgrounds can do well in substance abuse treatment and in drug courts. So one of the Urban Institute's comments as well for their policy recommendation is think about expanding what the criteria is. If you've had narrow criteria because you presume that would have better outcomes for your individuals in your program, not necessarily true. So really think about that. I think another element I would like to reiterate from the drug court findings from the Urban Institute as well is the role of judges in this. And I think that's one of the things that I've seen going around the country to different drug court programs, is really to see how important the role of the judge is. And it's one of those things that it's really hard to operationalize and hard to measure, but you get feedback from individuals in the program that when they feel that they've been engaged and respected and understood and treated consistently and fairly, they have better outcomes. So importantly, I would emphasize that as a finding. On the whole, this is another slide just talking about the outcomes for individuals with co-occurring disorders, emphasizing that for those individuals moving into the community, getting treatment in a prison setting now, in this particular data from SACS, you see better outcomes when you have that transition and continued care in reentry in the community. So we need to think about that longer-term tail, that longer-term intervention for persons, particularly with co-occurring disorders, and the effects are there in terms of reductions in recidivism. So overall, when we look at the data, it says that we have better outcomes for individuals when you combine supervision and treatment orientation. Those are your best outcomes. So across the continuum of care, whether it's an outpatient, whether it's a part of drug court, whether it's part of the in-prison program and moving into reentry, we can say that drug treatment is effective, it changes lives, and it saves money. Thanks.
I'm going to share my new word with you. It's called snow globing. So you know what a snow globe is. You all know what a snow globe is. It's that little thing that you get Christmas time primarily, but also when you're a tourist and you go to New York and you get an Empire State Building in the snow globe. And you shake it up. So the snow's all laying out one way. You shake it up and it falls down, and it falls just a little different. And in government, we have a tendency to snow globe a lot. We say, oh, you know what? We're going to target, in the people that do substance abuse treatment and mental health treatment for children and families, we're going to target child welfare families. So you shake up your existing resources, they fall a little differently, and you say, oh, now we're going to serve that. Well, why you're serving that, the people that are getting the drug court treatment for years are no longer, because you have to take the resources from somewhere. So unless you create new resources, you end up just moving chairs around and doing that. And Holly gave a couple of examples of that, I thought. So we know that the dose is important. We know that. So what do? We say, well, let's put more people through the program, so let's cut down the dose. Again, snow globing. We're trying to get more without any new resources. So what we end up doing is we end up creating less effective programs rather than using what the research tells us. The Opaga Drug Court report that just came out, it's the post-adjudicatory drug court program that was created by the legislature for the purpose of keeping people in the community that traditionally would go to prison. So in the past, if you got 44 points, you went to prison in the what's that official document called? Yeah, Department of Corrections. What's that official document? But you know, where they add up points, all your priors and everything, and they say, oh, yeah, and it says, okay, you go to prison, 44 points. Well, the legislature said, well, let's try something different. Let's raise those points and see if we can't keep some of those drug offenders in the community. So they raised it to 52 points, and then they got bold and raised it to 60 points. And Opaga has been evaluating this program for 5 years, and they just released a report 2 weeks ago in the legislature, in Senator Evers' committee. And what we found is the programs that were having the most impact were those that were doing it the way it was set up to be done. The programs that were having the least impact were those that were using it, like for instance in Orange County, a lot of people are in the program that have below 22 points. Well, they were eligible for regular drug court, not post-adjudicatory drug court, but what we were doing, as Ed Latessa said yesterday, is we're taking higher rate, lower offenders and putting them in a higher intensity program than they needed to be. We found out that in Polk County, for instance, and there's a lot of work being done on targeting this, but in Polk County, they were not doing drug court, but the judge wasn't, people were coming in and signing in at the drug court, where in the other courts, the judge was involved, just like Holly just said. And when the judge was involved, it was more effective. So that's another example of where you have to pay attention to what you got to work with to do it. So what we're going to do now for a few minutes is talk about some innovative programs that are working with drug treatment to change offenders' lives. And I got two people that are going to do that. Patrick McInerney is a Senior Vice President and Regional Director with Phoenix House, and Chet Bell, who is the CEO of Stewart Marchman Act Behavioral Health Care, both leaders in innovation with offenders. So the floor is yours.
Who's going? I'll defer to you. All right, I'll jump first. Hi, everybody. Does this work? Yes, it appears to work. How about that? Just a couple of things I want to talk about briefly. And for those of you that know me, you may say, "Hey, this guy keeps talking about the same stuff." But I'm gonna stay on this bandwagon. I'm gonna talk a little bit for a minute about the front end of the system, and then I'll talk a little bit later about the back end of the system. But those of you that know me know that for the last 14 years, Stuart Marchman Act has been involved in something we call, very sexily, the Anti-Drug Initiative, which comes out, for those of you that have been around for a while, remember when the National Office of Drug Control Policy had their whole anti-drug campaign back in the late 90s. But about at that same time, in Volusia County, we'd had a drug court for 2 years. We started drug court in '97. And in '99, the then state attorney in the 7th Judicial Circuit, John Tanner, came to us at SMA and said, you know, we got drug court and we think we're dealing with the right group in drug court, people that have serious criminal histories and also lengthy treatment histories. We think we got the right population for drug court. But we got this whole big other group of first-time drug offenders that from the state's perspective, we want to do an intervention with that group, but we want to divert these folks as much as possible out of the justice system. And oh, by the way, we don't have any money. But what we'd like you to do is, see if you can put together a program that would address those individuals. Well, how many are we talking about? Oh, geez, there's a couple thousand of them a year. That sort of thing. So we went to work and we started looking in the literature that existed at that day regarding effective programs, particularly brief interventions. And we came upon something in the minutia of the literature that came out of the National Institute on Alcohol Abuse and Alcoholism, NIAAA, that was called Project Match. And Project Match was a study that was done where they attempted to take 3 emerging at that time interventions in substance abuse, motivation enhancement therapy, cognitive behavioral therapy, and tried and true 12-step self-help, and create brief interventions, manualize them, and then did studies across the country regarding the relative effectiveness with that. And they attempted to match, based upon going back to Latessa, they attempted to match people as best they could to which of those 3 interventions they thought would work best with each individual. And at the end of the study, they found that while there was real evidence of effect with each of those 3 manualized interventions, when they were done appropriately, consistently by trained staff, what they didn't find was that there was any evidence, whether people were matched correctly or incorrectly, that they did any better or any worse. So while that may go against a little bit of what Dr. Latessa was saying yesterday, it certainly coincides with what he says about whatever kind of treatment that you use, make sure that you're training staff well and that you are practicing it with fidelity. So at any rate, flash forward 14 years later, we've now had more than 15,000 people go through a 6-week brief intervention based on motivation enhancement therapy. For the first 10 years that we did it, 2 sessions were one-to-one with a counselor and then 4 group sessions. And keeping up with the time and the volume and in attempting to keep the cost of the program low, it's a $300 intervention, which is paid for exclusively by each of the individuals that come to it. About 4 years ago, we put it all online, so that now those actually 7 sessions in total are done by the individual essentially in the privacy of their own home or at the library or wherever they can access the internet over a 30-day period. And the program is designed in such a way, those of you that have ever been DUI, or not DUI, excuse me, driving school scofflaws, I didn't want to call myself a DUI scofflaw, driving school scofflaws know there's lots of ways of getting around the driving schools in their online programs. And there may be with what we do too, but one of the things that you can't do is just go in and do it all in one session. you have to, you can do Chapter 1 in the first few days, and then the program locks you out for several days so that you go over a 4-week period. And you also have to drop 4 clean urines during that period in order to successfully complete the diversion and have at that point, the state attorney dismiss the charge. And as I said, the program is based on motivation enhancement therapy. So it's really self-discovery on the part of the individual regarding what they see as the pros and cons of their drug use and where it's getting them to this time, and helping them make some decisions about, as a first-time offender, what they want to do going forward in their life. Really, no more, no less than that. And here's the reality of it, what we know over those 14 years. About 5 out of 6 people complete the program, about 82%. About 16%, they're not matched well to this program, and they either fail to complete the sessions or they can't provide 4 consecutive clean urines. And if so, there's a consequence associated with it. Rather than the incentive of having your charge thrown out, you have the consequence of the state attorney going forward with your charge. The other thing that we track, just very simply, is 1-year recidivism rates. And essentially what we know, we've got 3 categories. We've got completers, and their 1-year recidivism rate on any arrest in the counties in which we provide the program is about 20%. We have those individuals who don't complete the program, and their recidivism rates are more like 30%. And then we have a control group, and their recidivism rates are about 35%. These are drug offenders who are not involved in the program whatsoever. So that is an example. I go back to John Tanner and his smart justice vision as a state attorney 14 years ago. And there are other programs similar to it around the state, and over time we've tried to market it, give it away. At this point, I'm ready to just put it on Craigslist and say, you know, here it is if you're interested in it. And if there's somebody who's hearing this discussion for the first time today, I'd love to talk with you more about it, because I think it is a highly effective intervention with first-time drug offenders. Patrick? Does this one work?
Does this work?
Yes.
I think so. I was asked to come down and speak about some of the innovation that we're applying throughout New England and in Florida. And in following Ed Latessa's lecture yesterday, he's hit our states already. Vermont, we all do much of what he does. What we've been doing in Phoenix House, and we have corrections programs in California and Texas that I'm not going to speak about, but we have about 3,000 people on any given day in treatment in those facilities in California and Texas. But in the New England regions, we're in much smaller, obviously, locations. And we do everything from behind-the-walls treatment in a TC environment, if that's even applicable anymore, all the way out to 120 transitional beds for people both from the criminal justice system and from the recovery community in a series of houses that we call RISE, which is Recovery in a Sober Environment. So throughout the entire continuum, we do a couple of things that are constant. Every client gets an ASI on our electronic medical record, and every client does assessed. And every client's treatment plan is predicated upon those 2 documents and not a group, so to speak, although Phoenix House is probably very well known from the group environment. And we do that here in Florida as well. One of the problems that we're beginning to see is that when you talk about consistency of treatment, trying to look at it objectively and scientifically, what do you do when somebody comes in for a 7-day stay or a 10-day stay, 30-day stay, a longer period of time? How do you measure the dosage? How do you do all of those things? And I think that we're working through that as systems begin to respond to something that I really would like to talk to you about. Because increasingly, Well, how many people here are in the treatment business? And how many people here are in the treatment business with the Department of Corrections? Okay. What would you do if one of the larger Department of Corrections and one of the more innovative, I'm sure if we would have asked Ed yesterday, he began to talk about two out in Oregon and Washington, but said to you, guess what, folks, we're no longer in the treatment business. That's being said all across New England and other states who have participated in the Affordable Care Act and have expanded Medicaid. Because why would the Department of Corrections pay $48 million here when they could move that cost to the federal government and not pay one penny, either the state or the feds? And so many states are doing that. And they're getting out of the treatment business and into the risk reduction business, and using the tools that Ed Latessa spoke about yesterday. And we have a risk reduction program, and it's called Thinking for Change. It's designed by him, and we use that in those states. But so when I think about the innovation that's coming out, obviously what Chet spoke about and what other folks have spoke about here with drug courts and other tools that we've used over the years to get engaged and involved in the treatment business with people who are incarcerated or in probation or veterans in drug courts. We all know all of those terms, but what's really happening is a revolution in how they're going to be paid. As we move more and more people out of the prisons, you saw those numbers in your own statistics here. Those people go out into community resources. Those community resources can sign up somebody through navigators into the Medicaid pool and begin to get paid through Medicaid for the direct treatment of those folks. So a lot of the dollars that are spent previously through treatment are now being moved to other areas, whether it's housing, more prevention dollars, and things of that nature. And we see that not only in the substance abuse in the criminal justice environment, but we also see it in all substance abuse treatment now. The state of Rhode Island, where we have probably our largest New England facilities, beginning January 1 with the advent of the Affordable Care Act, no longer covers clients coming into any program for any reason. They gave us a, what was at first a 30-day, it might be a 60-day amnesty, if you will, for people who came in and could not be converted to an insurance product. But, and there are quite a few who can't. So that whole payment stream that we lived on for 45 years, dependent upon the state, send us a check, whether it was fee-for-service, contract, we all know those terms, but those people, many of them are leaving the idea of paying us and moving that over to a Medicaid managed care groups, and even a lot of corrections programs across the country are looking at things of that nature, especially signing up people on 30 days before they get released so that they can move over to probation and parole and not be involved in treatment programs with the state agencies, but treatment programs with and being paid for by Medicaid or Medicaid managed care. So I think that those activities are really changing a bit of the playing field. If we're going to see that happen, the work that Holly does and Ed Latessa does are primary to us because, as you know, in medicine, we've all asked for this to be treated as a disease. They don't want anecdotal information. I didn't point to you for that purpose, but they don't want information that we give them off our own research. They want validated research for what they're going to pay for. And so I think it brings, a lot of what we do and all of the words that we use in terms for our different approaches, evidence-based treatment, et cetera, has to be validated and has to be, every agency has to have the ability to translate that information. Hopefully I'm not taking up too much more time, but.
No, let's
Okay, Chet.
let Chet go again, and then you can offer a few more comments, and we'll move on.
Well, to bookend this, the other program that I want to talk about is Reality House. Reality House sits at the far extreme from the anti-drug initiative. It's at the end of an individual's prison sentence. And these, the individuals who come to Reality House, which is not far from Tomoka State Prison, not far, that's a key element, I believe, not far from Tomoka State Prison in Daytona Beach, are all classified by the Department of Corrections as individuals who would benefit from a therapeutic community as they come up on the end of their sentence. And we've dovetailed onto that also for as many of the individuals as we can, a work release experience. And, you know, over time, kind of in talking with inmates and talking with the staff at Reality House, we start to think about what's going on there at the end of sentence with these inmates as a kind of decompression. The average length of time that individuals have been in the state prison system when they come to Reality House is somewhere between 5 and 6 years. They're within 18 months of the end of their sentence. And in fact, many of them are not even really sure that they were going to ATC actually when they show up at the door of Reality House. And a lot of times they're very unhappy because they thought they were going to work release rather than another 6 to 9 months in a therapeutic community. But the elements of programming that are provided at Reality House and at other similar programs that are community-based around the state, I really do believe offer that transition, that is what we're really talking about in reentry, from living a life that's prison-based to beginning to acclimate to a life in the community and having the opportunity to address some of the deficits that you have while you are preparing to reenter the community. And you know, it's a short list. Having education, having a vocational skill, having an identification card, having some money in your pocket, knowing where it is that you are going to live and where you're going to work when you are released goes a long way towards addressing recidivism. And that's really what the purpose of Reality House is about. But I think the other thing that's instructional about it, Reality House sits within a classification of 5 residential therapeutic communities within the Department of Corrections. The other 4 at Broward, Gainesville, Jefferson, and Walton correctional institutions are all either within the institution themselves or they're on the grounds of the institution. And while I say that Reality House is within a half a mile, and all of the inmates at Reality House are included in the bed count of Tomoka Correctional Institution, the fact that it is outside of the gates and the fact that its setup is so dramatically different from the prison environment is another benefit in that decompression, if you will, and it reinforces the work of the therapeutic community. The role of the staff changes from correctional officer to therapeutic support and counseling and role model, if you will, in learning new behavior. And the program itself is, as Latessa talked about yesterday, again, is all about developing new ways of thinking and then having your attitudes and your emotions follow through from that. We've found for those individuals who don't have an education, and about 2 out of 3 who come to us don't have a GED or a high school diploma, that getting that taken care of while they're in the program is critical. And if they don't have a skill or a vocational trade, given the fact that Reality House serves as our central kitchen for our entire agency, provides us the opportunity to do, not unique, certainly in corrections, but provides the opportunity for good training in the culinary arts. And in particular, for anyone that operates a food operation, the ability to provide enough coursework and enough training that individuals can earn a food manager's certificate. And a food manager's certificate is an extremely valuable credential for any individual upon release. It pretty much guarantees them the opportunity to go to work in the field, because it's a much sought-after credential, because you better not run a restaurant without a certified food manager on site, or you're going to run afoul of a health department inspection. So a therapeutic community coupled with work release, where an individual moves from all of their movements being just within the program to now going out into the community, working, and then coming back to the program at night, kind of furthers that decompression concept. And again, any outcome data that we report related to Reality House is the Department of Corrections data. It's not our data. And frankly, I wish the data was more intensive, more current, more all-encompassing. Because we believe that we're reducing recidivism by at least half, and probably more. But our data is dated, and it's not comprehensive. For example, we've got data that 2 years after release, inmates from 2007 and 2008, according to DOC's data, had only recidivated at rates of 5%. But we don't have the same kind of data looking in more recent times. At any rate, on the back end of the system, we believe these kinds of programs, providing this reentry and the opportunity for people to decompress back into the community, are truly going on all around the state, and that's what reentry is all about. So just wanted to talk a little bit about that today. And Andrew Williams here, who is Reality House's program director. Andrew, raise your hand. And if you want to know anything more about Reality House, please check with Andrew, because he is the straw that stirs the drink. Thank you.
Is Tadar still in the room? I remember going to, when I was doing the juvenile work, Chet's talking about people learning a skill. And I remember going to this juvenile program and at Home Builders. And it was a deep end juvenile program. I think it was MAC high risk. And this kid had a tool belt on, and it had all the tools on it. And I walked into the room, and he had the biggest smile on his face that I'd ever seen. And I says, "What are you smiling about?" And he turned behind him and he went, "I built that wall." And it just makes, to me, it still resonates about if you can teach somebody something different and they can practice it, then they have a chance to live a different life. So let's talk about that for a minute. So when we were getting challenged, when the budget was really bad, and remember that slide I showed of the blue graphs where we went from 1,900 beds down to 1,000 beds, and now we went back up to 1,100, those are community treatment beds? Well, we were threatened with some pretty dramatic cuts. So we were looking at, so how do we address that? How do we deal with that issue? And this is how we did it. We created a thing called Susan's Story. And this was a story of a woman who the judge said, "You're going to prison for 5 years. However, I will give you one break, one chance, and that's to go to this program called Susan B. Anthony." And she made it through the program. And she was pregnant. And what we did is we just cost out, what would it take to put that woman in prison, put Susan in prison for 5 years, which means in Florida, you are going to serve 85% of your sentence, so you can calculate how many days that is. You know it's a woman, so it's $75 and $74 and something a day for a woman in the Department of Corrections prison system. And she has other children that you're going to have to pull away and put in child welfare. So you add that up, came up to $152,000 plus dollars. And then she went to the program. And the program cost $10,290. It's pretty simple to realize, boy, it only takes 1 of 15 to break even. So we brought Susan to tell you a story, but I do want to tell you. So I bring Susan to Tallahassee, and she's walking around with her baby in her stroller, because her baby was born at the treatment program. So she's walking around with her baby in her stroller, and we're trying to say, and Barbara's there, and we're trying to say, let's save these programs. So legislators would go up to her and go, "Oh, what a beautiful little baby." And Susan would go, "Yeah, you want to see my picture? See, I was arrested." And had this program not been there, I wouldn't have my baby. So, welcome, Susan.
Wow. It's been a while. Barbara, I remember I had dinner with you. Yes. What an adventure it was. My daughter was about 6 months old when I met Mark, and I was up in Tallahassee advocating for substance abuse dollars to stay in place because I know what they did for me and my family. And what a journey it's definitely been. And I just want to take you back just a little bit to explain to you how I got to that journey and how I was looking at 5 years in prison and how my life was just completely spiraling out of control. I obviously didn't look like this. I was probably about 80 pounds lighter, and I was probably kind of like a tinge of green and yellow because I was dying. The disease of addiction, I'm sorry, it gets me very emotional. I'm still emotional by it because I'm very grateful today. Because there's not a lot of us that make it. So it's really important for me to be here, and I'm grateful to be here today. But 7 years ago, a little over 7 years ago, my life came spiraling to an end, at least for me, at least I thought it was, because I was facing some serious prison time. 5 years is making light of it because that was a minimum sentence that I was going to get, because my life was stealing, prostituting, using drugs, doing whatever I could do to self-medicate to get out of myself for various reasons. And I was very, very fortunate that Judge Andrew Siegel, I'll never forget that. He gave me the opportunity to turn my life around. And I didn't know what to expect, didn't know what was going to happen. I thought I was going to go in treatment and go back out and use again. But I met some very, very powerful people that helped me see that the substance was just something that I put in my system to cope with everything else that was going on in my life. And I was able to start making changes, and my life started transforming. And in 2007, I reunified with all 5 of my children at Susan B. Anthony, so I was even much more grateful, because each year in sobriety, I got something back. My second year of sobriety, I got married to my 5th child's father, very amazing man who has been very supportive of my madness, because now I love what I do, and I love who I've become, and I volunteer a lot, and I advocate a lot, and I speak as much as I can. But my life still continued on an onward swing upward, and I kept advocating as much as I could. And I became a Florida Certified Peer Mentor and was able to become employed at Susan B. Anthony, working in the field with women that were at risk for losing their children. And I would go in and mentor them and help them into the program and the journey of recovery, so that way they could change their life around, that they could see that the program actually works if they really work the program and they abide by the first principle, which is honesty. And the program went very well, and Susan B. Anthony was CARF accredited and got the silver award for that outpatient program in home services that we collaborated with ChildNet, the Broward County Child Welfare System. So I was very grateful to that, and then I continued on in my journey and became a case manager at Susan B. Anthony and started helping the women stabilize their benefits, because there's nothing worse than coming into treatment and not knowing how you're going to buy your child diapers or how you're going to afford formula or what you're going to do for a living, because I was still homeless and I had to figure it out. And I had a GED and a few college credits, and that was about it, and a prison sentence hanging over my head. Nobody really wanted to employ me. It was definitely a challenge. And I continued on, and I just kept putting one foot in front of the other and kept working my program and kept showing up, just like the program teaches us. You just have to show up. And I graduated Broward College with my AA degree and went on to pursue my bachelor's degree in psychology at FIU, which I graduated with high honors. I wanted to know why my brain allowed me to walk out of a marriage and walk away from 4 children and go out and just get high. I just couldn't understand it. It was very powerful, and it was very baffling, and still to this day, if we could figure it out, I think a lot more people would be standing here than me. But it's just an amazing journey, what has taken place in my life, and I've just continued on, and I became the residential supervisor over at Susan B. Anthony, where we house 62 families currently, and I supervise 9 residential managers, 2 nurses, and 2 drivers. And I just continued pushing because I believe that we can just keep giving back. I stayed in the middle like the program showed me, stay in the middle and keep it real. I've kept it very real because I've seen a lot of women, I've attended a lot of funerals, and I've watched a lot of children be removed, and that's the reality of addiction, and unfortunately it still happens. I've showed up in a lot of courtrooms, and I've tried to advocate for treatment for as many people as I can, because I know that if someone is given the opportunity that I was given and is able to meet the program requirements and do what they're told to do and to follow the suggestions, that there's a hope that they can make it, and there's a hope that they can be a mother to their children. And that was important to me. It was really important to me because I had caused a lot of destruction in my children's life. I left one of my children homeless, and one of them was facing 2 double life sentences for armed robbery. And I was sitting in treatment, and there was nothing that I could do, because that's the way I left my children. But today I make a conscious effort not to look back, because I can't change my mistakes. All I can do is prevent making future mistakes. And fortunately, all my children are home, and they're all safe, and everything is going well. My rights have been restored. I finally went through the new DCF law change and was able to fight and get my appeal so I can have my DCF Level 2 clearance and continue working in the field. I'm actually interning as well at Memorial Community Youth Service with adolescents in substance abuse. I work in the diversion program and civil citation to educate as many youth as I can, so that way I don't have to serve them in residential treatment. It's an amazing journey, and I couldn't have done this without the dollars being available and without treatment being available. So I'm very, very grateful to the program. I'm grateful to many of you. Mark, I'm indebted to Mark and to those powerful people that are up there fighting for the dollars to remain in treatment. My journey still is on. I have about 1 year left in my master's program. I've been certified as an addiction professional, waiting to take my exam in March. And I'm just going to continue putting one foot in front of the next and continue helping the next addict that I can, because I can't keep what I have unless I give it back. And I'm so grateful to the program. I encourage you all to reach out, visit programs, see what they're all about. If you haven't been there, which I'm sure you have, come down and see how Susan B. Anthony runs. I'm fortunate I got another promotion. I'm actually a program supervisor, so I work over residential admissions and case management and the outpatient program, serving the families in pre-care. And I also just was invited to become a consumer representative for BBHC, Consumer Advisory Board, so that way we can kind of collaborate and see what it is that got me where I am today and what works and what we need to look at changing. And I appreciate you all being here and letting me share my story with you. Thank you.
You know those days when you wake up and you go, why am I doing this? I got to be careful. She's going to have my job pretty soon. On that pathway. The other thing that's really powerful is the story. And we don't do enough telling the story. So, as Marion Johnson said earlier, you got to get involved in politics. What you got to do is you got to tell the story. Because there's so much wonder and miracle in recovery. Recovery from mental health, recovery from substance abuse, recovery from juvenile justice offenders. And when you meet recovery, you go, this is all worth it. This is all worth it. And what I find amazing, and I thank people like Representative Pilon and Senator Evers, because what I find amazing is when I started this job 8 years ago, I went to Senator Jones, and I said, I want to talk to you about substance abuse. And he said, was that a problem? I don't hear much about that. So one of the things we've been doing for 8 years is talking about it. In every place I go, I say to people, talk about it. Talk about what you do. Talk about what's changing. Talk about what's happening. Talk about it. And now legislators are talking about it. Hardly can go into a committee meeting where they don't say, if we don't do something about substance abuse, we're not going to. If we don't address mental health, we're not going to stop this revolving door. So it's really important to talk about it. So with that said, do we have any questions? We'd be glad to take any questions from anybody about the value of what we're trying to do with substance abuse services. Come on. Then I think it's time to take a break. We'll be back here in, I think at 3:15, right? 3:15. Thank you all very much.